Well, thank you, Dr. Zeng, and thanks to organizers. Thank you, Dr. Zeng, and thanks to organizers for giving us this opportunity to talk about patient activation measures. It's a very interesting topic, and it's becoming even more interesting now that CMS is making it a quality metric. We report no conflict of interest, and over the next 25 to 30 minutes, what we would like to cover is what is this activation thing? We would like to talk to you about what is known about it, mainly coming from literature from non-dialysis patients and from non-kidney disease-related research. We will shed some light on what's available in the dialysis literature, and most importantly, Emily Watson, my colleague, is going to talk to you about what is it that you're going to do once you know about it and once you measure it in your patients. We've all heard this sentence before, and it's wrong on so many aspects. This patient is not compliant, and the way it's wrong, it's because it's putting the blame on the patient when in fact it's a lot of other things around it. And I hope we can cover some of this in this talk. You've all been there, and you have some patients who are probably laid back, not responding to what you tell them. You keep coming back at them time after time, telling them about what they need to do and how they need to improve their health situation. And we call them disengaged. And on the other side of the coin, or the other side of the spectrum, we have the engaged patients, the patients who know everything that they need to know about their disease. They even sometimes know more than us. They come into clinic visits, they have their questions written and ready to go. They, when there is something that they need to know, they know where to get it from, and they know how to manipulate the system, manipulate their way through the system, I should say. We call these people on the left side disengaged, on the right side engaged, and that's a way to think about activation, which is slightly different, but very related. And these words are used interchangeably. Disengaged people have low activation. Engaged people have high activation. Hibbert, who did a lot of work in this domain, talks about activation and what is involved in activation, and talks about activation as being in the core of engagement. Engagement is a bigger term, if you like, which involves activation, the interventions that you do to get the patients activated, and the resultant behavior. But activation itself involves three things: knowledge, skill, and confidence. I'll talk about these more in a minute. And the reason we care is research has shown that activated patients, or engaged, if you like, they are more likely to have healthy behaviors such as following up on immunization and screening checks. They have healthy behaviors in relation to eating and exercise. They avoid health-damaging behaviors such as illicit drug use and smoking. They follow up with their doctor's visits. They are adherent to their treatments. These are all behaviors that we'd like all our patients to have. And as I said, it involves knowledge, skills, and confidence. Where it matters here is every time we have that type of patient who is not responding and not doing the right thing, what do? We come at them with trying to improve their knowledge. We come to them with education focused on just letting them know what we think that they should know. And it's wrong. It's not only knowledge. They need to have the skill and they need to have the confidence. It was a fascinating talk by Wilson just now, talking, and I heard it over and over again, the confidence and the small steps. That is all part of activation. You have an activated patient, they can achieve a lot. Does it matter? Yes, it does. Look at this. If you have patients with low activation, they are more likely to be hospitalized. They're more likely to be in the emergency department. And of course, that is associated with high cost. And the item in the middle here, satisfaction and experience, is amazing. If you have two patients, one highly activated and one low activation, with the same provider, the one with higher activation is going to have more satisfaction with care. Do you know why? It's because they know what they need to know. They know the services exist. They know how to get the services and how to move through the system. And of course, the one with low activation is always disappointed, and they don't know what is already available to them. So what I told you so far is patient engagement and activation are two sides of the same coin. Activation involves knowledge, skills, and confidence. Activated patients follow healthy behaviors and they have better outcomes. So you'd ask, okay, but how do I measure it? And if you interact with any patient for a length of time, you would be able to tell if this patient is activated or not. But you'd like something more than that. You'd like a way to be able to measure it, give it a number so that you can follow the patient over time and see if they're improving or if they're regressing. You would like to be able to measure it for all your patients and know where they are so that you know how to approach them. And yes, you can measure it. There is a 13-item survey called the PAM13, Patient Activation Measures 13, and it gives you a score between 0 and 100 or levels from 1 to 4. And as you would imagine, the higher the score or the higher the levels, the more activated the patient. The survey is available online. You can Google it, PAM13. And I would suggest that you actually go through the questions and you fill them for yourself. Check out what it means and get a feeling of what it is about. As I said, 4 levels. Level 1 on this, what you see on the screen on the left, these are the patients who are disengaged and overwhelmed. And on the far right, you have the patient who is at level 4, who's doing really well and who knows what they need to do. And this is what we know about it, comparing the dialysis patients to non-dialysis patients. On the screen, you see 4 columns. These are the 4 levels. Level 1, the lowest activation. Level 4 on the right, the highest activation. On the first row, you see dialysis patients. On the lower row, you see non-dialysis patients. And look at the stark differences. Level 1, just look at level 1. In the non-kidney disease patients, the lower row, 10 to 20%, as in 1 in 10 or 1 in 5 patients are low at that low level of activation. Look at the dialysis patients percentage, 44%, close to half the patients in that study were at level 1. That is very worrying. Look at the other extreme on the right there. Non-kidney disease patients, 20 to 25%. That is 1 in 5 or 1 in 4 patients have that high level of activation. Dialysis patients, 5%. That is 1 in 20. 1 in 20 hemodialysis patients have level 4 activation. That is very worrying. This is another study. I'm putting it up here. The biggest thing about this one, this is coming from UK. The first one was for Belgium. The biggest thing about this is that it shows you hemodialysis and peritoneal dialysis patients on the same slide, CKD and transplant. Just look at the green bar and the purple bar, peritoneal versus hemodialysis. As you would imagine, PD patients have to be more activated. Otherwise, they wouldn't even be able to perform home therapy. But this slide demonstrates it more and brings the message home. This was not about activation, but it's about highest power and choice versus lowest power and choice, the two sides from the left side of the screen to the right side of the screen. And what you see here is the journey of chronic kidney disease from early CKD all the way to in-center hemodialysis. And as you would imagine, in general, patients who have chronic kidney disease or transplant or on home dialysis or self-care, they're all doing better than the in-center hemodialysis patient. The in-center hemodialysis patients have the lowest power and choice. They surrender their power over time because of the overwhelming information that they get and the care providers that they see and the way that we want actually to box everybody in the size and shape that we think is right for the patient. We take out their will. Very briefly, And interestingly, actually, last year, this same meeting, we talked to you about the studies that we wanted to start about patient activation. And I'm very glad to tell you that a year later, we have presented 2 posters about patient activation in the last American Society of Nephrology meeting a few weeks ago. Very briefly, I'll have to be brief because of the time limitations, but I'll show you some highlights about these 2 studies. The first one was in prevalent dialysis patients, and it involved 925 patients across 10 dialysis units. The average score was 56. Remember that this is anything between 0 and 100. And in this slide, what I'm showing you, low activation is level 1 and 2. High activation is level 3 and 4. 65% were low activation. 65% is about 2 out of every 3 patients were level 1 and 2. That is very worrying. That is hemodialysis patients, prevalent hemodialysis patients. We looked across age groups and gender and education, and it's interesting. The older the patient is, the less activation there is. Females did better. Education-wise, the higher the education, the more the activation. In incident dialysis patients, we ran a study across 182 incident dialysis patients in 37 facilities. This is interesting because it involved home patients as well. And what we did is we took the patients at the start, and then we monitored the activation status at month 4. The activation status was 65. This is higher than the prevalent dialysis patients, if you remember that. And what that tells me is that the more they stay on dialysis, it's more likely that they are lower activation, or they lose that activation across the time. And this is interesting as well. Home dialysis patients had higher activation, and the other factors that you would imagine would be associated with activation. Look at this: longer pre-end stage renal disease nephrology care was associated with higher activation. So in summary, yes, you can measure it. Score between 0 and 100, 4 levels. A large proportion of dialysis patients have low activation. Very quickly, CMS is proposing that it becomes a model, becomes part of quality measurement in the CKCC model. And they're recommending that you measure it for at least 50% of your population, excluding patients with cognitive impairment, and that you do a follow-up PAM13 survey at least 4 months after the baseline survey, and you can exclude patients at level 4, patients who are at level 4 at baseline, you can exclude them from the follow-up. So with this, I'm going to hand it over to my colleague, Emily Watson, to talk to you about, okay, what can you do about it?
Thanks, Dr. Hussein. So I'd like to share with you, pick up right where Dr. Hussein is leaving off, and you're going to hear some themes that were brought up in our earlier presentations, wonderful presentations today, just reinforcing some of the great information we've heard already today. When we talk about the PAM, what's in a measure? Well, I think a few things. Mainly, I think it's an opportunity. I think it's an opportunity to obtain a level and a score that will help us identify current risks, current issues, as well as future issues that our patients may be bringing with them. It also brings the ability to assess health literacy. I'm going to talk more about that because I think health literacy is key to work with our patients. We can stratify and identify risk groups with this information, the PAM leveling. We can then allocate our resources, and we know our resources are precious, and so using them wisely is really going to be to everybody's advantage. We can select appropriate interventions or surveillance programs for those that don't need as much intervention. So today I'm going to talk about 3 different areas or kinds of interventions that I propose are options when working with the results of PAM and patient interventions. So we have chronic disease self-management and self-care, peer mentoring, and motivational interviewing. So a quick word about health literacy. As I mentioned, I feel that health literacy is key to working with patients. If I can give you the definition by the Affordable Care Act about health literacy, it is the degree to which an individual has the capacity to obtain, communicate, process, and understand health information and services in order to make appropriate health decisions. So given that I'm going to be talking about some self-management strategies today as core components for effective management of a chronic disease such as chronic kidney disease, you can imagine that low health literacy scores can pose considerable health concerns. You can see here in this infographic, the CDC notes that low health literacy can see our patients visiting the ER or the ED more often, spending more time in hospitals, less likely to be those patients that adhere to our treatment plans, and are going to have a higher mortality rate. So it truly is important, and there's more research being done, so much so that the Department of Health and Human Services added this time to the Healthy People 2030 into their framework and overarching goals, more study on health literacy. So more to come on this, but keep this in mind as we continue this talk today. So as an intervention, chronic disease self-management programs are wonderful, and we've seen them in many, many different fields. This is actually from Diabetes Education, a study that was done with 345 type 2 diabetic patients. They were randomized into a usual care group and a 6-week community-based peer-led diabetes self-management program. So we have some peer support here. We have the education and the management program, self-management program at play. What they found was not necessarily a great improvement in the A1C scores, but at 6 months, they found improvements in rates of depression, symptoms of hypoglycemia, their interactions with their physicians, as well as better and healthier eating habits, including reading food labels. In addition to these, they also found that these patients had significant improvements in patient activation and self-efficacy. Again, that being that confidence to act on the information that you have. They studied again these patients at 12 months after this intervention and found that these patients continued to demonstrate these improvements. So it really shows that chronic disease self-management programs have certain focus, one being a set of skills to develop action plans, another to be modeling. In this case, they use that peer mentoring modeling to show how to make steps in the right direction for positive health outcomes, reinforcing beliefs, again, the confidence needed to make positive decisions. And lastly, that persuasion element, that's that elbow grease that you get with one-on-one interactions. So is there a role for this in CKD? I think so, and ESRD. This is a beautiful infographic that came out in ASN looking at what was called shared HD. This is another way to look at engaging patients, and as Dr. Hussein referred to, engagement and activation. Using self-care here really did bring about greater activation. Activation meaning making movement towards more positive actions. They looked at 600 patients in over 12 different sites. And what they did, as you can see in this stair-step model, is they took patients from this I won't and I can't do it to the I did it, sort of like we heard in Wilson's beautiful story. On the right-hand side, you see a set of actions that were offered to these patients. And what the goal of this study was to increase patient participation in their own treatment and then align this with what is called person-centered care. It allowed for individual preferences, patients to choose what they wanted to do and go at their own rate, allowing some to start with those more simple tasks and others to jump into those more complex tasks. The outcomes were, as you might imagine, very positive. Patients moved on to home dialysis. Patients took on more activities and became more independent in centers. And ultimately, this kind of a study showed it would to be a gateway to more independent and home dialysis, all wonderful actions, right? So these are very specific interventions looking at a specific disease model. I'm going to change and talk to you now about motivational interviewing. Many of you may know of what this is and some may not. So let me introduce it by saying it was developed back in 1983 by William Miller and Stephen Rolnick. And what they worked in was the field of addictions. So motivational interviewing originated working with addictions, namely alcohol, but has been used with nicotine and smoking cessation and gambling and pills and all kinds of other addictive behaviors. Over the last 20 years, however, it has moved into the management of physical health conditions such as diabetes, heart disease, and asthma. This intervention is used to help patients increase their motivation to change their behaviors by the behaviors that prevent them from making positive health choices. Motivational interviewing is a counseling method, and it helps people resolve those ambivalent feelings, the feelings of, I want to be well, but I don't want to take my pills. I want to be well, but I don't want to stop drinking so much fluid. And really identifying those ambivalent feelings and then finding the internal motivation within the patient that they need to change their behavior. It's a practical, very empathic, person-centered, and short-term process that takes into consideration really how hard it is to make change, and it allows for celebrating successes. So by empowering patients to resolve those ambivalent feelings and finding that internal motivation, also allows the patients to identify their own problems and what they want to address as a behavior change, to therefore set their goals and their strategies and build a self-care plan. And this is truly building upon self-efficacy. The first goal in motivational interviewing is to increase one's motivation, and then the second is to get a commitment for change. So how can this be applied to dialysis? Motivational interviewing does require training and practice. It is a skill set that is developed, and it is utilized in very intentional ways with multiple visits and follow-up. It's been taught in the field of social work, and you may know social workers that are trained in motivational interviewing. I know I do. But it's also being used in the medical field, and I'm seeing more and more work out there that is being brought to physicians, to nurses, to dietitians. So how can we bring this to dialysis? It's about resource allocation. I think the time and the intention put into motivational interviewing with a patient can't be done by everybody at all the time. So allocating a resource, a person that might be your specialist, could be your social worker on site, but identifying the goals with the patient. And this is what can be brought to those IDT, again, interdisciplinary versus multidisciplinary teams, and addressing health literacy. And you've heard me talk about how important this is. So quickly, health literacy to understand, for patients to understand and make good choices. Chronic disease self-management is very successful in self-care, and motivational interviewing as a way to elicit sustained improvements. So Dr. Hussein mentioned that we did some studies at Satellite, and I got some feedback from the social worker to the ones that helped administer these surveys. And I asked them about the burden of bringing this survey to them. And obviously there were some. There were literacy issues where the patient struggled to read and understand, for example, the Likert scale. There were language issues, there was timing issues, and then the administrative burden of managing this survey for sure. However, there were some great learnings and impressions that my team shared with me. One being that this survey, the PAM in particular, is very strengths-based, which means it focuses on encouraging and empowering a patient and focuses on the positive. I can do, I am participating. It is distinct from the quality of life. It is not the same as KDQOL, nor will it replace the KDQOL. It really does look at a different avenue. It's looking at activation. However, if and when the PAM does come into ESRD or CKD world, it will be very complementary for sure with our quality of life surveys. But it did underscore very clearly the distinction between literacy, regular literacy, and language issues, and the health literacy issues. And it helped social workers identify who was going to be struggling with understanding their treatment plans or what was in front of them with their ESRD diagnosis. And it really is a major area of focus, I feel, for providers in the healthcare field. What's missing? Well, a whole lot, actually. As Dr. Hussein mentioned, the PAM has been studied in many different fields, but it's newer to the ESRD and the CKD world. So this was an article in JASN over the summer that points out where we have room for more work, including what is really the right amount of time to study a change or an impact of an intervention on a PAM score, right? And how long do these impacts last, doing a longitudinal study. So as much as there is plenty of work left to be done, what I would love for you to take away from today's talk is an interest in learning more about patient activation and a measure like the PAM, understanding where the role of a self-management program or motivational interviewing could play a role, both in your own practice or in the broader center that you work, And most importantly, take this conversation back to your teams. Talk about tailored, person-centered approaches to your patients, and focus again on health literacy with your patients. So, as Dr. Martin Luther King said, faith is taking the first step, even when you don't see the whole staircase. So, thank you for having us, and I will stop there and allow for any questions if time permits.
Great. Thank you so much, Dr. Hussein and Emily. Anybody has any question, please put in the chat box. Kevin has a question. Where can I learn more about CMS Patient Activation Quality Initiative?
You want to speak to that, Dr. Hussein?
Yes.
You're on mute.
Can you hear me?
Yeah, there are shared documents with organizations who are involved in CKCC. These are not public, but the best resource is the Nair's perspective article in the Journal of the American Society of Nephrology meeting that Emily referred to in one of her last slides. I'm going to put a link to it in the chat box.
Great. Kevin Fu has a question. You mentioned that there were around 5% of HD patients achieved the ideal level activation engagement. Do you think lacking motivation, patient education, family support, and health literacy have something to do with such a low percentage? If yes, what are the steps you can take to overcome the barrier?
So Emily is our expert. I think she can take this one.
I think that absolutely psychosocial issues, support services, family, all of that plays a role in a part of activation, right? Being able to have the confidence because you have those supports in place. However, I do feel that patient activation can also be a measure of the internal sentiment that the patient has. Now, a patient with multiple resources, financial, social, medical, may feel much more confidence and may score higher with your activation scores. However, I wouldn't want to say that you can't have somebody have a high activation and a high sense of self-efficacy and confidence who might lack, say, in those financial and social resources. A lot of this has to do with personal empowerment, which can be truly independent from those external resources.
Great, thank you. Nina Concepcion has a question, is how much is our government involved in prevention at CKD 3 and 4? Apply more than actual treatment. Is there already a legislative body working on this type of coverage rather than just focusing budget on ESRD? Probably a hard question.
Well,
very hard one, yeah. Go ahead, Emily.
Well, I might harken back to our welcoming presentation today about the presidential order looking at truly increasing education about ESRD, CKD. I think that organizations like the NKF spends a lot of time and energy working to increase this and get the information out there that 1 in 7 adults is likely to develop CKD and move towards end-stage renal disease. So I think as much as we want support from the government, and there is some, we also need to take it upon ourselves, right, to find ways to spread the word through both being involved in organizations like this, but word of mouth and talking with all 7 people around us, because one of us probably may be moving into the realm of CKD ourselves with the percentage of 15% of all Americans. So I do think part of the awareness is on our own, and the other part we can look to our organizations as well as our government.
Excellent. Thank you so much. So we will finish here, and our next presentation will be back on 1:25. Thank you, Emily. Thank you, Wael.
Bye-bye.